Welcome to our podcast series, Conversations Navigating Breast Cancer, where I, Dr Ettienne, will be asking the questions that you, the listener, are too scared to Google. And our guest speaker, Dr. Ettienne, an oncology surgeon in the head, the neck, and the breast, will help us untangle the serious facts, but also bust some myths around breast cancer. Welcome, Dr. Ettienne.
Thank you, Dr Ettienne. I think this has been a long time coming. We've been threatening to have a chat for a long time. So, at long last, here we are.
Here we are. So we're going to start our first series on self-breast examinations and mammograms. So I would like to know from you, why is self-breast examinations important?
The short answer is you have to get to know your body, because women have vastly different breasts from one another. So there's not like one recipe for what a breast should look and feel like. And generally the two breasts are not exactly the same and not symmetrical. And I think if someone gets to know their body, they will pick up differences that there may be. If I'm a doctor and I see someone once a year or the first time in my life, my question is, has this lump always been there or not? So I think that's the important part. Is I think women shouldn't be scared of touching their breasts and should get to know their breasts and what it looks like normally and what it feels like normally. And I think it's in my mind much more about awareness. No one is expecting the woman to become a doctor and a breast cancer specialist. The only thing we want you to be is to be sensitive about what your body should look like. And when there's something that change, then it means you have to bring that to the attention of someone else.
So from what age would you recommend?
Well, remember, in young women, breast cancers are infrequent. So, I know this is a podcast about breast cancer, but there are many other things that can go wrong with your body and many other things that will develop. So I think the first thing I want to say is young women, young girls should get to know their breasts and the way their breast changes over time. We see things like fibroadenomas quite commonly in young women. And the problem is now they discover this lump for the first time when they're 17 or 18. And generally the mum freaks out much worse than the daughter. Partly because of this whole thing of, it's a breast lump now, there's a risk for breast cancer. So if young girls get to know their breast and they understand that, wait a minute, I have a lumpy breast, this is not abnormal, and they find that there's this little thing that's getting bigger, and they know also that they're not a big risk for cancer, then I think that's also something that could put their mind at ease. Now, in terms of breast cancer specific self-examination, generally, I would say from about the age of 35, you should be a little bit more cognizant about changes that happen in your breast. We do see breast cancers in patients in their 20s very, very infrequently. Those are generally patients with genetic reasons for getting breast cancer, but we are seeing incidental breast cancers that start occurring in the 30-year age-old group. So I think that is when women should start being a little bit more vigilant about getting to know what their breast look and feel like. And also the breast doesn't change that much in short periods of time. So it's a good age to start.
And what should you be looking out for? So if you examine your breast, are there certain things that you should check and notice?
Everybody always thinks about a lump. The problem I find is that a lot of women don't really know what a lump really feels like. So they feel an area of density in their breast, which a lot of young women have. And then they say, this is a lump. So let me start off with what are the things that should really never be there. So you should not stand in front of the mirror one day and lift your arms and there's a dimple that's being pulled on your skin. If you notice a change in the contour of your breast, dimpling or pulling in, it looks like something sort of tugging on the inside of the skin. That is something that needs to be investigated. Number two is, if your nipple has always been an outie, then it shouldn't become an innie. Now, there are some women that always have nipples that are inverted. Frequently, during pregnancy and breastfeeding, they will be fine. They'll breastfeed. But they'll also tell me, Doctor, my nipple's always been like this. But if you've had a nipple that's always been outside and it's always been the same as the other side, and all of a sudden it starts pulling in, that's something that needs to be investigated. Remember that all of these things, it's not always like, oh my goodness, this is definitely breast cancer. All of these things are things, there are many other reasons why that may happen as well, but it needs to be investigated. The third thing is your breast skin should be soft and pliable and shouldn't have dry patches on it and things like that. Now, so if you've always had nice and normal breast skin, and all of a sudden there's this area of your breast that's become sort of thick and almost leathery, the French word is peau d'orange, which means like a peel of an orange. So you've got these little dimples where the little hairs are. That really shouldn't be there. Now again, maybe there for other reasons than cancer, but I think that's important to note. Then let me come to the last thing. When would you worry about a lump? Obviously, if you've had completely soft, fatty, smooth breasts and now all of a sudden there's a lump. Now that might be a cyst, it may be something benign, but that's new. A lump that is mobile is more in favor of something that may be benign. A lump that feels like it's tethered to the surrounding tissue. It's not moving around a lot. That's the type of thing you should be a little bit more worried about. And certainly, if you feel a lump and you also notice some of these other changes, that should really be a red flag. So my feeling generally is any of those changes, then you go and see your doctor, have a good clinical examination. If you're in the right age group, you have a mammogram or whatever, the appropriate investigation, and take it.
Discharge of the nipple, that should also be...
A discharge of the nipple is actually a sign. It's always mentioned when you talk about self-examination, but it is actually very infrequently a sign of breast cancer. So the majority of patients with a nipple discharge is not due to cancer. It's usually due to changes in the breast ducts. We call it ductictasia. But I would say if you do have a discharge that is persistently coming from one duct on your nipple, and especially if it contains blood, then I do think it should be investigated. Or if you've never had any discharge from your nipple and all of a sudden you now start having this, I think it's something that you need to go and see your doctor for, yes.
Mm. I've heard of ladies who were pregnant and felt a lump, and then some of the doctors have told them, no, it's a milk gland. What's your opinion on that?
If you are breastfeeding, your breast is producing milk. There is a small chance that you have a segment or a part of the breast that's not draining well, and that you then have a buildup of milk in that area. And if that area continues not to drain, if it's completely blocked, then that milk may become thickened, almost like yogurt. So you can get that. But I do want to say it's always a diagnosis of exclusion. So if someone is breastfeeding and they have a lump, they go to the breastfeeding clinic or they try and massage or try and clear that area specifically. And if in spite of everything you've done, that lump persists there, then it should be investigated. And you can only say that it is a blocked milk duct or a galactocele or something like that once you've sort of excluded that there may be something a little bit more solid in that area.
So if you're pregnant and you don't have the baby yet and you've got a lump, do you still have those milk ducts?
When you go through puberty, your breast develops, but it remains immature. So this is something people don't always know or understand, is your breast remains, let me use the word childlike, until you have a full-term baby in your arms. So, and only then does the terminal unit of the milk globule develop fully into an adult milk-producing organ. Now, like any childlike cell, those cells are much more susceptible to things that cause cancer changes than a cell that is mature. We don't do x-rays and CAT scans and things unnecessarily on children because we know the effect of that is much worse than doing it on an adult. Now, if you do stuff to your breast before you've had your first child that has a risk of breast cancer, those effects will be much higher than those same things that happen after you've had your first child. So first thing is the breast only matures once you have a baby. Now, in this maturation process that happens during pregnancy, your breast is busy growing and changing and making more tissue. So in the very last part of your pregnancy, you may also notice that there starts being a little bit of fluid that comes from the breast, preparing you for breastfeeding. Generally, these changes could result in a lumpy or a dense breast, a full breast, but they shouldn't develop a distinct mass or a distinct lump. So if there's a very prominent lump that develops during this process, that could be abnormal, and one should definitely have it seen to. The difficult in a pregnant breast is it is a breast that is dense, that is difficult to evaluate, and the problem is that cancer can hide away there. So if it is a cancer, it can frequently be missed because doctors say, oh, well, you're pregnant, that your breast is just dense, it's difficult, you can't really do a mammogram. So I think if you have a mass that persists, and especially if it feels like it's getting more prominent over time, if your gynecologist told you 3 weeks ago, don't worry, it's a milk gland, like you say, and you're worried about it, then you go back 2 or 3 weeks later and you say, listen, I'm not happy with this. I'd like us to just have a look at this because, as I say, there is a small risk. We do have breast cancers in pregnancy, and it is important that we pick those up.
So obviously you find a lump, now you're in panic. So I often say to people, if the lump persists for longer than 2 weeks, would you agree or not agree? Should one then have it checked out? Or because with your normal menstrual cycle, normally one would say you would do your self-breast examinations 2 weeks after you've had your menstrual cycle.
The time of the month theoretically that your breast should be the softest is a week before you start menstruating. So that's generally about 2 weeks after you finish the previous cycle. So I agree generally that if you have a tender breast with a lumpy, firm area, and that doesn't change over the course of your cycle, then I would say 2 to 4 weeks. If something persists, I think, you would never be wrong in going to seek medical attention and ask someone to examine your breast and just see what it looks like. I also sometimes see patients and I'll say, okay, let's just have a look and see what this looks like in 2 weeks' time and just make a decision how active should we be in investigating this. So, yeah, I think that rule of 2 weeks, it gives a bit of time for you to watch it. And if it then settles down, then you don't have to worry that much.
So what I've read is that when you turn 40, you go for a mammogram yearly. Is that what the guidelines say? Or what is the guideline?
So I think the whole routine screening mammogram, it is a controversial issue in the sense that we have very little scientific evidence about how much it adds. So I think my advice to patients generally is, number one is you should always have a clinical breast exam, probably from the age of 35 on a yearly basis. So if we compare patients let's say between 40 and 50 who has a mammogram once a year, or they have a clinical breast exam only, and obviously if you feel something that's weird, you are going to have a mammogram, but you don't have routine mammograms, then actually the data says you are picking up sort of similar amount of breast cancers. And it's not as if we have there's a lot more people dying of breast cancer because they didn't have mammograms. So I think my first message is always, not doing a mammogram doesn't mean the same thing as not having a breast exam. So I also don't think that you should have a mammogram only and no physical examination of your breast. The combination is definitely the best. In South Africa, we don't have a screening program for breast cancer. If you are living in the UK, there's a definitive screening program that's run by the NHS. You get an invitation through the mail to say you're eligible now to have a mammogram. If I'm not mistaken, I think that's every 3 years. Again, that's the way they do it. And they go and they have a mammogram. They don't have a physical exam. That's the way they do it. There are other countries that will do more frequent examinations. If I look at all the literature and all the research about breast cancer screening, I think I've come to the conclusion, if I have to give patients advice to say, I think we should do a risk-adjusted screening program, which means if you are someone that has a low, let's call it a normal risk of breast cancer in your lifetime, which in South Africa means you have about a 10 to 11% chance of getting a breast cancer somewhere until you are 90 years old. Those patients are probably fine to have a clinical breast exam from 35 onwards, probably start doing mammograms at 50, and probably have a mammogram every second year. And then up until probably 70 to 75, continue on that regimen. And then when you get to, let's say, 75, you have to ask yourself the question, how good is my health? Am I going to live more than another 10 years? And if the answer is yes, then you probably continue on your routine. If you are someone that has a moderately high risk for breast cancer, so those are people that have a breast cancer risk that is going between, let's say, 15 and 20% for their lifetime.
But how would you now evaluate that? Is it a family member?
Yeah, so we'll talk about how do you do a risk assessment. So if you're in that middle risk group, then probably you should start having mammograms a little bit earlier. And I would generally say have a mammogram when you're 40 and see how dense your breast tissue is. And then you should probably then consider having a mammogram once a year, at the latest once every second year. But again, have a breast exam every year from 35 onwards. If you are someone that is a high-risk patient, those are patients that have a breast cancer risk above 20%. Those are basically people that I am considering to have genetic testing on. So this is someone that has a mom that had breast cancer at 35 and a aunt that had ovarian cancer. There's a lot of risk factors that are playing a role. Those patients are ones that really should have an intensified screening program. So they should start earlier, probably around 30. You don't do mammograms at such young age. So those are patients that we would screen with MRI. Those are also patients that I would advise genetic testing for. So that would be my approach, or if I see someone, that is my approach in terms of how I decide how often and when the patient should have mammography. Now, if you have a very healthy patient, she's not overweight, she's not using alcohol, she's doing everything right. She's got no family history, so she's sort of an average risk patient. She's got really dense breast tissue. She had a mammogram at 40. It's a very dense breast. You can hardly see anything in there. For her to rely on mammography only is going to be foolish. Often I find that they've got a smaller breast. The breast is actually not difficult to examine clinically. So I think the chance of finding something on a clinical exam is better. And I really don't have good evidence for her to have MRIs every year. MRI is also not a pleasant thing and it's expensive. So I think for me, it's about being sensible and what you want to achieve. And I think the part that people tend to leave out frequently is the part of the clinical exam. They tend to think, if we think screening, we think mammogram. And they don't think, but actually that's just one part of what a screening program should look like. Now, you asked about how do you determine what your risk would be? And I think there are several breast cancer risk assessment tools that one can potentially access and use. Several of these tools can be found on the internet. The Gale model is the oldest one and one that is fairly widely used. It's a fairly simple one to do. It takes things like your age and your family history and stuff like that. So if you Google Gale, Gail model, you will definitely find one. One that I think is a little bit more comprehensive is the Breast Cancer Surveillance Consortium Risk Calculator, the BCSC calculator. So again, if you Google BCSC Risk Calculator, you'll get to their page and it starts the invasive breast cancer risk calculator, and then it asks you lots of questions that you basically answer. They're not difficult questions, and it'll then give you a lifetime risk estimation, and that gives you an idea of where you are. I think what's important to remember about these things are that they're not South African. Mm-hmm. So in South Africa, we have a lot more genetic breast cancers, for example, in the typical Afrikaans family hereditary type of pattern. So just always keep that in mind. But I think it's still a good idea of where risk is. And then I think the last warning I want to do is I do sometimes see someone that says, well, but I felt this lump 6 months ago, and then I did this risk calculator, or my doctor did this risk calculator, and it says, oh, but your risk for breast cancer is only 8%. And then I said, oh, thank you, goodness, and I left it. So if your risk is 1%, it means 1 out of 100 people will have breast cancer. Mm-hmm. And for that one person, it is 100%. For the rest, it's 0%. So don't think because your risk is low, you can't have breast cancer. You still have to address the issues that you are faced with, like a lump in your breast.
Mm. So what I want to ask about the mammogram is where do you see the place of a mammogram? When is it important? Obviously, if you find a lump. But every now and again, you get women that go for their screening test because they're over 40, and then they find something called microcalcification. Maybe you can just elaborate?
Yeah, um, so we in the medical field we talk about overdiagnosis of breast cancer, which means that you are diagnosing breast cancer unnecessarily. It almost doesn't make sense. You would think, with what, how could it be bad to get diagnosed with breast cancer? And I always, I think about a simple example is if you learn that you have breast cancer and you are upset and you are, your husband's crying and your children are upset, and let's say 4 days later you go on a vacation, you're in a car accident and you die. Terrible, obviously. But the fact that you've now been upset for all these days didn't make any difference in the fact that you had this car accident. So we have people, and it's the older you get, the more other things there are in your life that is also threatening you. Heart attacks and strokes and other cancers that are much worse than breast cancer. So the problem often is that we do diagnose a group of patients with breast cancer. We turn their whole life upside down. And in the end, the breast cancer is never the thing that actually causes a problem in their life, because there are other competing problems. So we do overdiagnose a certain percentage of breast cancer, and the older we get, the more that percentage becomes. Things like microcalcifications tells me that there's something in your breast, in that spot, that is irritating the tissue. And because of that irritation, little crystals are starting, like a pearl that forms in an oyster. There's something that rubs their little sand kernel, and then what happens is the oyster starts putting stuff around that piece of sand, and then it builds up a pearl. So your breast does the same. Something irritates it. There's inflammation, there's irritation, and then there's little bits of calcium that then gets deposited there, and we see that on a mammogram as a calcification. Cancer can be an irritation in your breast. Things like in situ carcinoma, which we'll, hopefully in one of the episodes get to. In situ carcinoma can do that. Now, some things can cause that has no threat to your life. A blocked milk duct, a previous bump or a trauma on your breast, previous surgery that you've had, someone that smokes that has duct ectasia, for example, if you've had a breast abscess. So there are lots of things that can cause microcalcifications on a mammogram. Not all of those are cancerous, but the problem is once I see them on the mammogram, I now have to do a biopsy, which is not a pleasant thing to go through. But it's the only way you're going to know what's going on there. And then, you find something like ductal carcinoma in situ, DCIS, which in itself is not a danger to you. It's something that may become a problem over time, but it's not really something to be afraid of right now, for example. So patients between 40 and 50, we take 1,000 women and we do a mammogram on them every year for 10 years. In 60% of those patients, we will find a flag, a red flag, or something of concern throughout that 10-year period, which will say, ma'am, we're seeing this little thing. We're not sure. I think you should come back in 3 months' time or 4 months or 6 months' time. Now that poor patient is like, okay, but what is it? And, what happens if it gets bigger? And so for the next 6 months, she's now worried about this thing that they saw. So in 60% of patients, somewhere in that 10 period of time, we are going to make their life worse than what it was before they had the mammogram. It's not cancer, but it is something they worry about. We are going to find about 18 patients where we're going to say, oh, wait a minute, this may be cancer, and we're going to do a biopsy, and we say, okay, well, congratulations, it's not cancer, for example. Now, that figure can vary. If you do yearly mammograms, that can be as high as sort of 50 of those patients. And then we're going to have maybe about 5 or 6 that we're going to say, oh, we found a breast cancer with you. So it's this double-edged sword that we are finding breast cancers, but we're also finding things that are adding concern and anxiety and, I want to say just sort of, shuffles your life around a little bit that that isn't cancer. It's not busy saving your life, but it does sort of detract a little bit from your peace and joy as we go along. So that's always the problem with anything we do. There's this small amount of things that we add to that for the benefit. Now, obviously, if you take the patients between 60 and 70, we find a lot more cancers. So we are yielding a lot more cancers. And because the breasts are easier to look at, we see a lot fewer things that are false alarms. So we are making their lives a little bit less anxious. So, and that's part of this reason why I'm saying probably we can start it a little bit later, or we can do a little bit less, because we can in some way then sort of reduce. Some way there's a balance between how much anxiety I want to cause and how much benefit I want to impart on the community.
I think we spoke about it once where you told me that by the time that the cancer, you've got the lump, it's been developing for how many years prior to that? It's already started. So to become anxious about something that you pick up now and want a biopsy in 2 weeks and start your chemo in 3 weeks, it's not going to make a difference on the outcome.
Yeah. So again, I see this patient and it's a breast cancer, and she's like, "But doctor, I don't understand this because I've been going for my mammograms every year." And this is exactly the thing: is we can't prevent breast cancer by doing mammograms. We can prevent colon cancer by doing colonoscopies, because we can find a polyp and we can take it off and we can prevent that from becoming cancer. But breast cancer doesn't have a benign lump which then becomes cancerous. So breast cancer is cancer from the start. It's slow and grows slowly, and until it then gets to the point. So by the time you can feel a lump, it's anything between 5 and 10 years that those cancer cells have sort of slowly been fiddling around there and finding their way. And the problem also is that the really bad cancers, the ones that we are afraid of, or the ones that are really, I want to say, life-threatening, the triple negative breast cancers, they are sometimes the one that the patient says, "But doctor, I had a mammogram 3 months ago. There wasn't a lump. I saw my gynecologist. Everything was fine. And then like 6 weeks ago, I woke up and I felt this lump. And from that time until I got this appointment today, it feels like it's double the size." Now, the mammogram didn't help that patient. It didn't pick it up. And there's nothing that she could have done to sort of warn herself that this is coming. So the cancers that are really concerning are the ones that mammogram doesn't help a lot with. It helps us to diagnose it, but it doesn't help us to sort of suspect that it's going to be coming. And the ones that are these sort of slow-growing type of tumors are the ones that are much less likely to kill someone. So, whether you have a mammogram now or in 6 months, or sometimes even I want to say in a year, whether you pick it now, then probably doesn't make such a big difference. As long as you don't miss a cancer until it's 4 or 5 centimeters in size. I think that's the thing is, whether you catch it at 8 millimeters or 12 millimeters or 70 millimeters probably does not really make a difference in the danger that cancer presents to you. Cancers, like people sometimes are born with a certain personality. If it's born bad, it's going to behave that way. If it's a cancer that's slow and innocuous, it may sometimes, I see elderly patients that sometimes have things for 10 years, sometimes come with a huge tumor of 5-6 centimeters, but it hasn't spread anywhere. So again, it's the personality, it's the behavior of the cancer that's important, and mammograms don't change that. So I think, again, screening, getting your to know your breast, being cognizant of breast health is important. Breast cancer is the most important, the most common cancer, but it is not the cancer that kills the most women. So I think it's important, but I think one should also not be overly, people tend to have lots of regrets because they missed a mammogram somewhere along the line.
So I think the self-breast examination is the most important thing every month. Would you suggest once a month? That's what you do?
Yeah, I think, again, I see so many different patient personalities. Some are really sort of, almost on it, and they organize, and you can see that they've got their little calendar, they do their breast. And then others are like, "Dr. Myburgh, I can't even remember to dress my kids in the mornings, so, how do you want me to remember this?" So it's a difficult thing, and I don't want to put extra burdens on people's lives. In a world that has lots of competition for your attention, there are lots of responsibilities. So I think try and get into a rhythm of, I almost want to say, when you take a shower at night, every night, just, wash your breasts with intention in terms of, I'm just checking and making sure everything's fine. When you get dressed in front of the mirror, just, when you lift your arms, have a look at the breast and just check. And that way, it sort of becomes part of your routine and not one of those things that I have to remember the second Sunday of July. I have to now examine my breasts. I find that generally doesn't work very well. There are not that many women that are diligent at that.
One last question. You often see these mobile units that do some kind of a thermal, I don't know what you call it.
Thermography, yeah.
Yeah, that's only going to pick up a lump or big lump.
So I come back to evidence. So everything that I do, I always think very carefully, what is it that we want to achieve? Number one. Number two is, what are the potential harms that I may cause by doing this? Because everything you do could have some harm to it. And number three is, if I do this to the person, what downsides, what side effects, why am I going to influence this person's life? And then obviously, what are the benefits that I'm going to give to this patient? And a lot of that needs to be driven by evidence. Evidence of, we had 1,000 women that we stood in front of a black door, and we had 1,000 in front of a white door, and we picked up much more breast cancers if the patient stands in front of the white door. Then I'll say, definitely paint my doors white in my practice, please. I want all of my doors white. So thermography is one of those things that have been tested, have been evaluated, and have consistently failed the test of, if I had to guess whether you had breast cancer or not versus asking this machine, then we end up with about the same result or the same amount of times that we right. So internationally, it is not advised as a breast cancer screening tool, and it's definitely not a replacement for things like mammography and examination of the breast and other things. So the idea behind this is that if you have cancer, it will attract more blood flow to that area, and the cancer area will be warmer than surrounding breast tissue. That's the principle around that. But the reality is it doesn't really work that way. There are some cancers that have a lack of blood flow. There are cancers that have a cystic space in it. In general, my advice is it may either cause false alarm and make you anxious about something that you don't know, and then you now have to run and find a mammogram and find a doctor because now this machine told you may have breast cancer. Or it may give you a false sense of security of saying, don't worry, I felt this lump, I was worried, but you know what, this machine said it's probably not cancer. And then you wait another 6 months and another year, and then you come to me with a cancer that's now being, really badly managed. So it's either the false positives, the false warnings, as well as the false negatives, the ones of putting your mind at ease. Both of those are not good with those machines, and I would definitely advise against using that.
Final question is the one on the mammogram. So often I get women who sends me this, I don't know where they get it from the internet, that says that the amount of radiation that you get from a mammogram can give you cancer, etc. So I've seen those statistics.
So people must keep in mind that the most amount of radiation that you generally get in your life is coming from outer space.
Yeah.
We're living in a universe that is inherently radioactive. Okay. So a mammogram will give you about the same amount of radiation as what you would receive in a normal week from outer space. So let's say you start doing mammograms at 40, you're very vigilant, and you do mammograms for 30 years. My question is, if you lived 30 weeks longer in your life, if I could add 30 weeks of extra life to your lifespan, do you think your risk of getting cancer in those 30 weeks would be significantly higher or not from just normal sun exposure? So the answer is no. So it is an issue if you start doing mammograms at 20, if you start doing mammograms before you've had children. So I think those are the issues that we face with. So yes, we don't want unnecessary radiation. We would like to have a sensible amount. So I think there's no evidence to suggest that patients who access mammography in a responsible way have any increased risk of getting breast cancer beyond their normal risk for their lifetime. That is really based on things like, did you have a television in your house when you were young? Are you drinking alcohol once or twice or 3 times a week? Are you overweight? Do you exercise 3 times a week? Are you a lawyer or a nurse? All the little things, we can definitely have a whole episode on what are all the theoretical risk factors that add to your breast cancer risk. But all of those things add a lot of extra risk to your lifetime risk versus a mammogram. So I can put everyone's mind at ease that having a mammogram does not increase your risk to get breast cancer.
Well, that wraps up our session on the conversations navigating breast cancer. Thank you, Dr. Ettienne. So we'll be chatting to you soon.
Yeah, Laurie, thank you. I think I enjoy this conversation. I think it's good to have an informal chat about these things and entertain my meandering thoughts about breast cancer after a career of sort of close to 30 years of dealing with breast cancer and all the research that we have on that. So there are lots more things we can chat about, and I'm hoping that this can be a more regular feature.
Absolutely. Thank you.
Bye.